So over the next 25 minutes, good afternoon, everybody. My job will be to talk about how we can manage effectively alcohol use disorder in alcohol-associated liver disease patients. And I think the rationale was very well outlined and spelled out by Steve in the introduction. So after the disclosure, I'll take a case which is my own case a few years ago during the COVID time. And this is a 34-year-old female who was hospitalized after a fall. And then she clearly has features of alcohol withdrawal, as you can see. And she has some comorbidities, metabolic syndrome. Her alcohol use is in the moderate range, 2 to 3 drinks daily since she was 16. And in the last 2 years, it increased to about 5 to 6 drinks daily, more severe. And then, more importantly, she had several healthcare encounters during her lifetime, including 4 years ago when she had a gastric bypass procedure. She lost 60 pounds, but she still carries a BMI of 28. These are her labs, which are, as you can see, are featuring chronic liver disease with alcohol-associated liver disease as an etiology, and imaging showed cirrhosis and clinically significant portal hypertension. So I think taking this case, there are certain, as you all may have noted in this particular presentation of the case, is certain points which I will go through over the next slides, highlight certain features this patient encounters. First one is that there were several encounters where there was an opportunity to identify a risky alcohol use and a harmful drinking, and maybe intervene to prevent cirrhosis, which was the ultimate outcome in this patient. And this was very well recognized in this publication almost a decade ago from Denmark, where 36,000 in this registry retrospectively shown a follow-up of 15 years. 5% developed cirrhosis, but majority of these had several healthcare encounters where there was an opportunity to diagnose AUD. And this was similar to what our patient in the presentation. So how do you identify or diagnose a risky alcohol use? And this is a tool which is most commonly used. There are several others, but for the sake of time, I'm putting the most common one here, which is, you all know, is alcohol use disorder identification test, or AUDIT. Is a tool where there is a test, 10 questions self-reported by the patient, each question on a scale of 0 to 4. But this is mostly used in research setting, and in clinical practice, it takes a lot of time. So a tool which is as good as the full tool is a brief version of it called AUDIT-C, and where you talk about whether the patient is drinking and the amount of drinking or the frequency of drinking, and then the binge drinking, which is the third question, 5 or more drinks. And that is also self-reported, a total score of 12. And if you score more than 3 in a female and more than 4 in a male, you can identify alcohol use disorder. If you end up doing the whole test or audit tool, you can stratify diagnosis of alcohol use disorder at a score higher than 8. And the higher the score, more severe is the disease or disorder. At 15, you can make diagnosis of more moderate to severe alcohol use disorder. And sometimes when you put numbers into what the patient tells you, it actually shows how severe the problem can be rather than just listening to the patient. For example, I'll just give you an example here. I saw this patient 2 weeks ago in my clinic. The patient is reporting to me she uses a Friday or a Saturday of the week, twice a month, so every other week. She will use 5 drinks at a time, 5 beers at a time. And if you listen that 5 beers once a time, every other week, that doesn't sound like a very severe kind of drinking. But when you put that number into this AUDIT-C question, she is claiming 2 points on all the 3 questions, making a total score of 6, which actually translates into a moderately severe alcohol use disorder. So that's why when you translate those numbers into this small AUDIT-C tool, which takes not more than 30 seconds, you can make a diagnosis there. Once you make a diagnosis of a risky alcohol use, then screen the patients whether they have underlying liver disease or not. Obviously, standard one is liver enzymes and imaging for any steatosis. Obviously, you have to exclude other liver diseases, Hep B, Hep C, and other liver diseases listed over here. And then if the patient has features of liver disease and you think that this is alcohol associated after you have excluded other things in a high risky alcohol use patient, the first test which comes to in a primary care setting very handy is a FIB-4, not only because it is fairly sensitive test, but also the algorithm which is used to calculate FIB-4 is very simple. You don't have to order very big numbers of tests. And at a cutoff of 1.3, you can segregate who is more likely to have a more severe liver disease or a fibrotic disease. And then the patient can have a second test, which is a fibroscan or VCTE, and a cutoff of 8, you can identify more. And then in a more specialized clinic, you can do more advanced testing, ELF test of MRE, and sometimes a liver biopsy. And this algorithm applies to patients, and you can stratify patients where you want to focus more on these patients who are more likely to be fibrotic and progressive. The second thing which we learned from this patient's presentation is she had a gastric bypass procedure 4 years ago, and then 2 years ago her alcohol use increased. Did gastric bypass procedure contribute to some extent her increased in alcohol use? And here are the data to show. On the left-hand side you see, and this is the veteran database or veteran study. On the left-hand side you see the MOVE program, which is a kind of a healthy lifestyle intervention in veterans. In the middle you see the sleeve gastrectomy patients, and in the right-hand side you see the gastric bypass procedure, the one which our patient underwent. And what I want you to see is the green bar and the empty bars, which is representing more severe alcohol use disorder compared to baseline when the procedure happened. At 5 years, you would see the moderately severe alcohol use increased in patients who underwent gastric bypass procedure. There was no much change in MOVE program and in sleeve gastrectomy patients, clearly telling there is an association that after gastric bypass procedure, not only alcohol use, but other drugs also, and more observational studies are showing that addiction to alcohol and drugs, other drugs after the gastric bypass procedure. And a third and a very important point, which our patient highlights, and you would have heard this several times in the morning in the session with MetALD, an excellent session Louis ran with Zubair and others, is dynamicity of alcohol use, that alcohol use is never static and it changes over time. For example, our patient for the first 15 years was drinking in the range of MetALD, and 2 years since presentation as cirrhotic patient, she was drinking more heavily in the range of alcohol-associated liver disease kind of drinking. So something to remember, not only when you are treating these patients or addressing the alcohol use disorder in clinical practice in clinics, but also when you're enrolling in clinical studies, because the alcohol use is the major factor to decide what kind of steatotic liver disease the patient has. So the phenotype might change depending on the frequency of drinking and the severity of drinking. So this slide shows, let me show you, summarize the follow-up and what happened to this patient at 1 year from the presentation. The details of the case in more detail are published in Gastroenterology and Gastro Grand Rounds, but here is a summary slide to show what exactly happened. So month 1, when she was admitted for the first time with fall and alcohol withdrawal syndrome, and she underwent AUD treatment at that time in the community in an inpatient program, and she remained sober for 5 months, but as the disease strikes, she was struck with alcohol relapse 5 to 6 months after, presented with varicose bleed, underwent ligation. A month later had another varicose bleed, underwent ligation, this time had hydrothorax, ascites, underwent a TIPS procedure, and then a couple months later came back with severe alcohol-associated hepatitis, was lucky to respond to prednisolone, went home on acamprosate, and then remained sober for 2 months, and a third episode of relapse happened. came back with recurrent alcohol-associated hepatitis. This time was not lucky, developed multi-organ failure, infections, transferred to ICU, and died. Bad outcome. And we all see this kind of bad outcome in our patients, especially with severe alcohol-associated hepatitis, a condition we just heard from Tim about that is a high mortality disease. So what the main point, which is the focus of today, is highlighted by our patient where she had multiple relapses. If she had not relapsed, she could have had a better outcome, and this is shown in several studies. And whether it is an early stage liver disease or advanced stage liver disease or alcohol-associated hepatitis, is that if you don't control the alcohol use, you are driving the bad outcomes like hospitalizations, mortality, or maybe liver transplantation. And if you improve your alcohol use, then the recovery can happen. We have seen patients where patients from the transplant list have been delisted just because they have improved so much, and recompensation even can happen. So clearly showing that alcohol use in terms of what happens to these patients in long run can decide the long-term outcome of these patients. That is what we will talk about. And this is a meta-analysis we were fortunate enough to be involved in, where there are about 90,000 odd patients, where 1/3 of these patients were treated with some kind of alcohol use disorder. And the reference population was who did not undergo treatment, 2/3 of them. 14 studies, you would see that treated patients had a less likely odds of return to drinking and translated into better liver-related outcomes, whether it is mortality or readmission and decompensation. So there is a benefit of improving long-term outcomes. However, in the real world, that's not what we see. It's extremely underutilized AUD treatments. And this particular study, I think, comes from Texas, if I'm not wrong. I think it comes from Sarah Lieber's group in UT Southwestern. I think Mac is sitting here. It is from his center, where only 2% of alcohol-associated cirrhosis patients underwent AUD pharmacotherapy, as you see in this cohort of about 27,000 individuals. And in alcohol-associated hepatitis, about 10% of patients got treated. What is the reason why does this happen? And I think this is something we should know, and in terms of how we address alcohol use disorder in these patients. Are we stigmatizing the patient? One of the things when we talk or write or talk to the patient or the semantics matter. So alcohol associated rather than alcoholic, whether it is hepatitis or cirrhosis or liver disease, so use alcohol associated rather than alcoholic. And secondly, exactly when we talk to the patient addressing their alcohol use, make sure that we are not letting the patient perceive that stigma, which I think is very common in these patients. So let me give you this video here, and this is a video. I don't think I'm breaching any kind of HIPAA here because it is openly available on YouTube. So I just put clips from the YouTube video. This is a guy who came in ER with a fractured ankle, and then the nurse practitioner who saw the patient in the ER is addressing her alcohol use. And I just let you.
So you've had some consequences related to your alcohol use.
Mm-hmm. I have.
So would it be okay if I give you some feedback about your drinking?
Sure, go right ahead.
All right. Well,
I figured that's where you're going.
Well, you're right. And so from what you've talked to me about, it sounds that you drink about maybe 16 drinks a week, about 4 or 5 drinks a sitting. Is that correct?
Yeah, that's true.
Okay.
That's true.
Well, so this goes over the limits for males and females, and the limits for males are about 14 drinks a week.
Mm-hmm.
And when it gets to be more than that, it can lead to negative health consequences like high blood pressure, heart disease, diabetes. What do you think about that?
Wow. It sounds like I should think about cutting back. That's what it sounds like.
So you saw how she, the nurse practitioner, gave the feedback to the patient in terms of her drinking in a very, very non-judgmental and a very empathetic kind of approach of this providing harms and brief intervention, what can be the harms of continued drinking. And let me show you another when you try to give feedback.
Scale 1 to 10, 1 being
and then
not ready to
motivate.
quit at all, you're going to walk out that door and have another drink, versus 10, how ready are you to make that change, with 1 being not ready to change at all, and 10 being I'm ready to change as soon as I walk out this door.
Yeah, 5 or 6.
Okay, well, that's great. I mean, 5 or 6, that's 50 to 60% ready to change. So what makes you
Yeah.
respond that way versus a 1 or 2?
Well, I sprained my ankle. My girl, she doesn't like it. Well, I'm gonna miss work. I'm not gonna get paid for the day and tomorrow. So there's a couple right there.
Okay. So what do you think, what kind of steps could you do to reduce your alcohol use?
You said I'd do like 14 a week and 4 a night. Well, if I went down to 3, that'd be less. I think I could do that.
You know, sometimes when I have patients making a change, whether it's dietary change or exercise or drinking, I have them write things down in a journal. Like, for example, with alcohol, how many drinks they've had during the course of the day. How do you feel about doing something like that?
Wait, I do it
Right.
every day. What would I do?
Well, you could write it down, either the number of drinks that you've had, and I could give you a journal to write it in, or if you...
That's for me?
This is for you. And you
Cool.
could write in kind of the days of the week are already set up in here.
Wow.
And you could either write the number down or just a yes/no response, whether or not you drank or didn't drink for that day. Sometimes, you know, people have a difficult time remembering things.
Hell yeah. Well, I'll start with the yes and no and see if I can do better.
So you saw how she involved the patient into the shared decision making, did the motivational interviewing part of the whole thing and giving feedback and some reaction plan. And let me show you 2 videos how you should not be doing it, but is a wrong approach. And you see right there, you will see the end result of the interview right on front of the face of that
Negative
nurse
health
practitioner.
consequences. It can cause cancer, cause things like pneumonia. It can damage your kidney, your liver, and those are things that, you know, you need to kind of function in your everyday life. And if you keep drinking, it will further impair those organs permanently. And it can lead to things like sexual dysfunction. You've already talked about having problems in your relationships, specifically erectile dysfunction. And also it can lead to accidents, and you could, you know, injure someone else, injure yourself. I mean, you wouldn't want that, right?
I don't know. And plus, I don't have erectile dysfunction. Where'd you get that?
Well, I'm not saying you have erectile dysfunction now, but if you continue to drink, that may be a definite consequence of you continuing, of
Okay.
your continued
No, I
use.
thought you said I had it. That's
No,
right.
no,
Okay.
no.
Nah,
And so, with that being said, I want you to think long and hard about this. And I think it's important that you need to change your behavior, maybe start going to AA meetings and just getting things back on track.
Wow. Okay.
What does that sound like to you?
Yeah, I'll think about it.
Okay. Well, how about we touch base in a couple weeks and I'll see where you're at.
What about my ankle? That's why I came here in the first place.
Right, that's right. And I'll give you a prescription and I'll have it at the front desk before you leave,
Cool.
okay? And I'll see you back here in a couple weeks.
Yeah, you might.
Okay,
You might.
all right. Well, good talking with you, Mr. Paul.
Yeah, you could see that right in that this patient is not going to show up for the follow-up because she used a wrong approach of addressing the alcohol use disorder. The other thing, I think, more than being trained for addressing alcohol use disorder is that we lack training also on using AUD medications. And more importantly, that we as hepatologists and gastroenterologists are focused on the liver care. And this is a survey of 400 odd gastroenterologists, hepatologists done from ASLD, published in CGH. And the major finding of this survey was that perceived by the gastroenterologists and hepatologists that they lack training on AUD pharmacotherapy, and majority, almost everybody said they want to be trained. And I think this is something which can improve the outcomes of these patients that our gastroenterology hepatology fellowship incorporate an AUD kind of a 7 or 8 week program where it can be effective and make them better hepatologists in taking care of these patients. And this is what we did in a pilot study, and this is under publication right now, and where 20 academic hepatologists we took who were trained by 7 addiction specialists on an echo-based platform with a weekly curriculum involving didactic presentations, case presentations and discussion, and there was a pre and post course evaluation showing an improvement in practice, competence and knowledge. So clearly in a pilot study it shows that maybe on a larger scale can be done the same, replicated this study to show the benefits of training with a small course of 7 to 8 weeks. So what are the medications to treat alcohol use disorder? The FDA approved medications, acamprosate is the safest. It has no liver metabolism. However, you should be cautious in people who have severe renal disease. Naltrexone, more and more observational data is coming to show its safety in decompensated patient. Disulfiram should never be used. Actually, the non-FDA approved medications, baclofen and gabapentin, have more data in liver disease patients. And then there are dual targets. We talked about GLP-1 and FGF21 where we don't have the clinical data, but GLP-1 has 3 randomized controlled trials, but not in liver disease patients. So those are something potential to be seen down the line, and I think industry is thinking of doing studies in MET-ALD and ALD population using these dual targets. So let me tell you 2 dual targets which are LGG and PUFA, and this is the LGG, and this comes from our center in Louisville from Dr. McLean's group. And this is LGG, and I think you heard from Tim about the FMT and the modifying the microbiome, and this is the same thing. I think when you modify the microbiome, whatever way you do it, I think it gives you a dual benefit on the liver disease as well as in the gut-brain axis with addiction. And this is what we showed in these moderate AH patients in a randomized controlled trial, that not only the liver disease improved, but more importantly at 6 months, the alcohol use decreased with this probiotic called Lactobacillus GG. And this is another thing which is polyunsaturated fatty acids. There's a lot of experimental data, but now more and more clinical data is evolving. And this is a trial which was done at NIH, where a baseline CSF examination was done, and 12 weeks CSF examination was repeated. And in the patients who received PUFA in a randomized controlled fashion, there was a target engagement in the CSF, and this translated into a decrease in alcohol use and then improvement in liver disease. So PUFA is something which can be, especially in early stage liver disease, can be a dual target. What about hospitalized patients? I showed you the data on very low rate of AUD treatments in this population, but I think this particular paper I put here to show that if you involve the hepatologists, because these patients are being treated by hospitalists and internists, the population is so large. So if you involve hepatologists and the social work or psychiatrist right at that point before the patient goes home, the chances that the patient will follow up, the chances that the patient will engage in AUD treatment is much higher. And this is what we need to do, is an integration program, whether it is in the clinic or hospitalized patients. On the right-hand side, you see a more apparent liver disease like alcohol-associated hepatitis. On the left-hand side, you see inapparent liver disease where the patient is showing up in the primary care, or the patient we just saw in the video in ER or in addiction centers. And then if they have liver disease, then integration with both. Because they have 2 pathologies, they need 2 doctors. And I think Dr. Morgan showed you this, the randomized controlled trial, which is currently happening in America at 6 different sites, including ours and MAC, which is in Texas, where the liver treatment with IL-22 will be integrated with AUD treatment using acamprosate, and then the long-term outcomes. More than the liver disease outcomes, we will also study the alcohol use outcomes, where the timeline follow back for alcohol use, and we will combine with PEth level as an objective marker. I did not put a lot of slides on PEth because it was excellently discussed in the afternoon. And then we have some metabolic outcomes and the patient-reported outcomes. So I want to summarize my presentation, and I think I made my point which was given to me treating alcohol use disorder, that we should screen for alcohol use irrespective what the patient comes for, whether it comes to the primary care or ER or to specialist. And then those who have risky alcohol use would screen for alcohol-associated liver disease. And we should address alcohol use disorder in the right way, we just saw, at every stage of liver disease because it helps. And then finally, we need strategies to improve provider training on alcohol use disorder, especially gastroenterologists and hepatologists, and then more and more promotion for integrated collaborative care models to take care of these patients in a more holistic way in terms of their two pathologies. And finally, clinical trials, actually, the one I just showed you is happening under the umbrella of NIH at 6 different sites, should be integrated also right from the time the patient is in the hospital, that they are treating liver disease and then they translate into an alcohol use disorder, not waiting for them to feel better from their liver disease and then introduce alcohol use disorder treatment. Start sooner than later to get better outcomes in these patients. I would stop here and thank you for your patient listening. And I want to acknowledge my collaborators, funding and staff, and more importantly, patients for helping us recruitment in the clinical trials. Thank you very much.